This first slideshow is on growth and development in infants. The information comes from several sources, including your books. So instead of you looking at all the other sources, I've given it to you, but you do need to read the chapter in your book. So this is a picture of a baby, looks up probably about 6, 7 months old, getting measured. We actually call it length and not height, but the general population calls it height. So I put height on here because I thought you'd recognize it better. We measure them either on a scale that looks like this. It's a board that has the centimeters or inches running alongside of it. You set the baby on it. You push up the little device so that his feet are flexed, just like our feet are flexed. When we stand, we want his feet flexed, and we want his head at the very top of the measure, the scale that we're measuring. There's several different ways and different devices to use to measure a baby, but this one is what you're going to see most often. Don't ever measure a baby by using a measuring tape from his head to his toe, because you won't get an accurate reading, and we certainly want an accurate reading. So the length of the baby, we usually measure them from head to heel length. And it averages, for the average infant, 48 to 53 centimeters. To be more exact, in the first 6 months, infants grow approximately 2.5 centimeters, which is 1 inch, each month. After 6 months and until a year, they slowly, sporadically grow. So we can't say per month, because they might not grow any 1 month, and then the next month they'll make up for it. So that by the time they're 12 months old, they have increased their length by 50%. So an example would be an infant that was 20 inches at birth, who is now 12 months old, should be, if they grow properly, 30 inches. 20 divided by 2 is 10. Picture of a baby getting weighed on a scale. Most of the time you'll see a baby getting weighed naked, because the ounces from the diaper can actually be kind of important in a tiny baby. They usually gain 1.5 pounds per month for the first 6 months or so. But what's most important to know is that by 6 months, they should have doubled their birth weight. And at 12 months, they should have tripled their birth weight. We need to make sure that they're following the book, because if they aren't, we worry about things like thyroid problems or failure to thrive or some other endocrine disorder. You'll see terms written in charts on babies, and they really won't explain it, but they'll talk about a baby that is AGA. So infants who are AGA are appropriate for gestational age. The average birth weight today is 7.5 pounds. The AGA usually falls between the 10th and the 90th percentile on the growth chart, and we'll talk growth charts in class. The SGA is small for gestational age, and we see this with our premature babies sometimes, and those babies fall below the 10th percentile. And so they're not appropriate for their gestational age because they're under the 10th percentile. LGA, large for gestational age, is babies that are above the 90th percentile. When we consider a birth somewhat normal now, I mean, we all weigh something different. Some of you might have weighed 9 pounds, where someone in your class might have weighed 7 pounds, and yet you probably now look approximately the same. So we know that what we consider a low birth weight is 5.5 pounds or less. Very low birth weight is 3.5 pounds or less. This baby's head is being measured by the nurse. It's called doing a head circumference. Generally, the measuring tape is put just right above the eyebrows and then around to the largest part of the baby's head. We expect the baby's head to grow 2 centimeters the first 3 months. Then it begins slowing down. It's 1 centimeter, 4 and 5. And then at 6 months, the baby's head slows down again, and it only grows like a half a centimeter until a year old. The baby has 2 fontanelles, one in the back that's called the posterior fontanelle, and one in the front called the anterior fontanelle. The one in the back, the posterior fontanelle, should close between 6 and 8 weeks. It's pretty normal to close. It's open mainly so that the baby's head could fit through the birth canal. The anterior fontanelle is actually open so that the baby's head can grow, so the brain can develop and grow. You may know the anterior fontanelle as a layman's term, a soft spot. If you put your hand on the soft spot, you won't hurt the baby. You can feel it pulsing sometimes. Sometimes you can actually even see it, and that's okay. What you want to look for when you're looking at the fontanelles is that it's open appropriately. Remember, the anterior closes 12 to 18 months, so it should be open. If it's not open and it's closed, the condition is called craniosynostosis, and the baby will actually need surgery to have that opened so that the brain can continue to grow. If the head appears kind of small in measurement, we worry about the baby having microcephaly. With microcephalic babies, many times they have other issues going on, including mental retardation. We want to look also that the head's not growing too quickly or too fast and getting too big. Sometimes there's a fluid between the brain and the skull called hydrocephaly. And the pressure from that fluid, it's actually cerebral spinal fluid, can put pressure on the brain and cause the child to be retarded. So this is also fixed. A little catheter is inserted. It's called a shunt. Actually, the whole term is a ventral peritoneal shunt. And they put this little catheter inside, under the skin, all the way up above the brain and down to the abdomen. And it drains the fluid and keeps it draining so that the baby doesn't have this increased intracranial pressure. Let me think of what else you want to know about this. I think that's it for the head. So this good nurse is cleansing the baby's gums. Yes, people should really wipe off the baby's gums even before they have teeth, and then continue wiping the teeth until the baby's over 2 years old. The teeth usually appear somewhere between 4 and 6 months. And usually by a year, most babies will have between 6 and 8 teeth. And we, of course, clean it with this, usually it's a wet gauze, but at home a lot of times people will use a wet cloth. Some babies are born with teeth and they're loose. They're called natal teeth, N-A-T-A-L, and they're loose. So we usually have to send them to a dentist to have them pulled so that their other teeth can come in properly. Sometimes babies will have little white spots that look like teeth and they're really not. Thank you, Scarlett. that usually, it really is nothing and it'll disappear, it'll be reabsorbed. It's a little calcium deposit on top of their gums, and it usually is gone 2 or 3 months. In the olden days, they called it a mother of pearl. And it said if your baby had a mother of pearl, they were smarter than other babies. I don't know how they could tell that. What we're seeing when babies are teething between 4 and 6 months, sometimes, we don't even know except they're drooling. They're not irritable, they're fine. But many times the baby will be putting their hands in their mouth. They'll be fussier than usual. They could tug at their ear, because the muscles are similar. And we need to teach the parents to do some interventions. So they can give the baby a pacifier that they kept in the refrigerator, something cold, or a cold teething ring. If the baby's over 6 months, they can have a dose of acetaminophen here and there, but no more than 3 days. Generally, the teething can take up to a month for one tooth to pop through, but usually the second one follows pretty quickly. So here's a chart of the baby's vital signs for the infants. You could see the temperature is pretty close to adults, although their metabolism is a little faster, so they're 37.5 to 37.7. We don't really panic with babies until their temperature is 38 and above. Their pulse can be between 80 and 220, and after they're 3 months old, it starts slowing down. So you'll see that it says 70 to 150. Respirations for a baby, interesting enough, are usually irregular. So you really have to count those for a full minute. In fact, we do apical pulses and listen for the respirations. We don't do a radial pulse like you do with your adults. So respirations generally range between 30 and 60. And usually, one time you check them, they could be 30, and the next time they could be, 60. And that's pretty typical. If a blood pressure is taken, and I'll tell you, they're not usually taken routinely on babies. Maybe if they have a cardiac issue, or if they're kind of worried that the baby isn't responding to things appropriately. So the average baby isn't going to have their blood pressure taken. But if it was, the systolic is between 65 and 78, and the diastolic is between 41 and 52. Many times you can hardly hear it on a little baby, and we have to use the Doppler, and we'll just get one number. So it'll be the systolic number. Gender plays a role in how high the baby's blood pressure is. The females are usually slightly higher than the males. So vision is very important with the baby, and you probably heard that babies can't see very well when they're born, and that's true. The infant vision is underdeveloped and it improves gradually. At birth, the baby can focus on objects 8 to 10 inches away. They can discern shapes with contrasts such as black and white colors, but usually no other colors. When you check their eyes, their red reflex should be present. Many times babies' eyes will wander in like cross-eyed babies until they're 4 months old. And that's because the ocular muscles that control our eyes, what they do, is weak. But by 4 months old, that's generally gone. If it's not gone, they need to see a pediatric ophthalmologist. So this is a little chart on feeding our babies. Babies need breast milk or formula until they're 1 year old. If the mom stops breastfeeding, the baby needs formula until they're 1 year old. Babies that are breastfed need a substitute of vitamin D because breast milk does not contain vitamin D. Premature babies, generally 32, 34 weeks, need extra iron that might not be in the formula or mom's milk because they tend to be anemic more than other babies. They usually will start the iron supplements at 4 months old, also for all babies that are exclusively breastfed. Juice and water are not needed the first 4 months. And after 6 months, when people can do a little bit of juice, it should go in a cup and not in a bottle. It should be diluted, and they should have no more than 4 to 6 ounces per day. Solid foods can be introduced between 4 and 6 months, and it's really important to introduce one at a time and look for allergies and to do it slowly. The iron fortified cereal is introduced first, and you can see the little schedule here. Then we do the vegetables and the fruits and then the meats. And everything is like a couple of weeks of each one to see if they're allergic to it. Nutritious finger foods such as cheese and raw fruit, but no grapes, can be introduced at 8 to 9 months old. Grapes are the size of the baby's trachea, so we don't want to give them anything that big. Anything we give the baby as far as table foods, it needs to be chopped up pretty small. What we used to say is the size of the baby's thumb nail, so that they don't choke on it. Chopped and cooked and unseasoned table foods are very appropriate by 12 months. The baby should be all on table foods by 12 months. Babies can be weaned when they show a sign of readiness and can drink from a cup. It usually occurs around 6 months or so. The last bottle to get rid of is the bedtime bottle, because it will just ruin their sleep if you get rid of it too soon. What's really ideal is when a baby is starting to have their cereal, their first solid, that a little cup of water or whatever is sitting there, or a little bit of formula in the cup is sitting there, and moms and dads can try. It can be a sippy cup, it doesn't matter, but they can try to get the baby to drink out of it. And then at every meal time, the baby is offered the cup after they're done eating. The baby's nocturnal sleep pattern should be established by 3 to 4 months of age, and they should, at 4 months old, sleep at least 8 hours. Babies at 2 months should sleep about 4 hours straight and then need to be fed. By 4 months, though, they should have a pretty good pattern and sleep better. They should sleep through the night and take 1 to 2 naps during the day by 12 months old. Okay, so this is a little table of the very, very infant motor reflexes. And I wasn't sure if you guys talked about it in OB with the new babies or not. But we look for these things because if the baby doesn't stop doing these reflexes at certain points of their growth, we worry that there's something wrong with the baby. This is part of our neural system. So you might have seen people say their babies can walk if they stand them up. Well, it's just a normal reflex. The babies will curl its toes and and kind of move a little bit. Rooting is a very common phrase that you'll hear. In response to stroking the baby's cheek, the baby should turn its head towards the touch and attempt to suck. When we have babies that have feeding disorders, we do this every time we go to feed them, and generally it helps get rid of the feeding disorders. You've seen a baby like startle, or you've heard about a baby startling. That's the moral reflex. In response to a shock or loud noise, the infant arches its back and throws its arms outward. So, read all of these over and be kind of familiar with them, because these are normal reflexes. We're going to talk about my favorite guy, Erickson, now. Trust versus mistrust. You probably have been told that there's Erickson has different stages, all the way up to elderly people. And, it's kind of right on the money. So from, the infant stage is trust versus mistrust. Erickson says that trust develops as needs are met. So as long as the baby is, fed and has a dry, healthy place to sleep, they'll trust the person. Those babies that aren't given that will mistrust the person. Mistrust develops when needs are inadequately or inconsistently met, or if needs are met before vocalized by the infant. So sometimes, the baby might be lying there awake and people go and pick the kid up. The baby like, wait a minute, I didn't call you. Or one of the reasons we always say, yeah, keep the baby kind of on a feeding schedule, maybe 3 to 4 hours. However, wait and see if the baby cries. The baby's telling you that he wants to eat. The social development is bonding and separation anxiety, which is generally 4 to 8 months old, and fear of strangers, which is 6 to 8 months old. And that even is grandma and grandpa, sometimes dads that travel. The babies all of a sudden are, act like they're afraid of them. Here's the body image changing. They know that mouth produces pleasure. They like to play with their hands and feet. And they later on learn that smiling causes others to react. Now for cognitive development is Piaget. So Piaget is kind of interesting in some places. I'm more fond of Erikson, as you can tell. And this is birth to 24 months. So some of these things your little one-year-old isn't going to do. But it's called the sensor oral motor. Oh, I can never say the sensor and motor phase. Sorry, I hope one of you guys can say it for me. The first one is separation, and they learn to separate from other objects in the environment. So this is kind of tough. They learn to separate from other objects in the environment. When infants are little, sometimes they have a special blanket or toy, and they think that's part of their body. As time goes on, they realize they can set it down and walk away, and it's going to wait there for them. It's not part of their body. Objects permanence is my favorite. It's usually around 9 months old. And before 9 months old, babies, like when they're learning to eat, will throw food over the side and think it's just gone. Where did it go? I threw it over the side of my high chair and it went to Never Never Land. But around 9 months old, the baby realizes when they throw something down, it's down on the floor. It hasn't disappeared entirely. Mental representation is a baby recognizes and uses symbols. That's like patty cake. Let's play patty cake, and the baby does it, or wave bye to daddy. That's they're learning to put things together. Piaget is really into language development. Crying is really the first form of verbal communication. And I always tell the older sister and brother when the baby's crying that really he's just trying to tell us what he wants. It's not crying like when you fall down and skin your knees. The baby vocalizes or coos and babbles and turns their head to the sound of a rattle at 3 months. So generally around 3 to 4 months, one of the big questions is, can your baby see and hear? We know that they can see, and usually around 4 months they can see pretty well. But can they hear? And then you will test it by shaking a rattle next to the baby. Oh, one of the best stages is 4 months when they actually chortle and laugh out loud. It's so great. By 9 months, they also comprehend the word no. So you say, when they're doing something, no, and the baby will stop and know that's harmful or he shouldn't do it. By 12 months old, we expect the babies to have 3 to 5 words other than mama and dada. Mama and dada are just the easiest sounds to make, and they're the first sounds babies make. And then they realize that those words are attached to these people that take care of them. So you usually say dada first. So I always say to the dads, don't get too excited. He doesn't know what he's saying yet. But in a month or so, he'll know it's attached to him. So we want them to say 3 other words. So it would be something like buy, eat, hot, cold, or no. No is probably the most common. So infant motor milestones is very important. And I found this great picture of it, and it's actually used by NCLEX and ATI. It's a picture of all the stages. So I'm going to go through the gross motor, but I'm also going to tell you the fine motor as well so that you get it. So at 1 month old, the baby demonstrates head lag. So you could see if you were pulling the baby up by the arm, the head would stay way behind. They have a strong grasp reflex. So if they put that hand over your finger, you'll say, boy, this kid's kind of strong. 2 months, they can actually lift their head off the mattress when prone. So as you pull them up at 2 months old, the head comes with the body. No longer will be having that strong grasp reflex, but actually now actively holds a rattle. And when it's lying down, he keeps his hands loosely open instead of closed like the newborn phase. 4 months old, they can roll from back to side. They will also hold an object with both hands midline, so they can roll back to side. 5 months, they can roll from front to back. They're able to grasp objects voluntarily, and they take objects directly to their mouth. We think it's teething, we don't know, but that's like their oral stage, and they're really fond of putting stuff in their mouth. Now back to this roll front to back. We put our babies on their back to sleep, so they don't get a lot of opportunity for rolling. So when babies are awake, they should have tummy time a few hours a day, and they should be on their tummy so that they can practice rolling front to back. 6 months old can roll back to front. They can hold a bottle, and they can pick up objects if they drop it. 7 months old can bear full weight on their feet. They can sit leaning forward on both hands. It's called a tripod sit. They can move objects from hand to hand. Now they can transfer. 8 months, they can sit unsupported. They can sit there by themselves. You have to put them in that position though. They use their thumb and their index finger in crude pincer grasp. It's called a pincer grasp. And that's a typical 9-month-old, and that's something we always look for in a 9-month-old to be sure they're not delayed. Oh, 8 months old, sorry, your book says 8 months old. But by 9 months old, they should be doing it. 9 months, they can creep on hands and knees instead of crawling. They pull to a standing position. That's like the creeping is like the army crawl. They can do that. They usually won't put their knees up just yet, but they'll get around by doing the army crawl. And if there is something like a sofa or something they can hold on to, they'll pull up to the standing to see what's going on. And now the pincer grasp is more precise. So, okay. So 10 months old, they change from a prone position to a sitting position. They can sit up by themselves, finally. And they grasp rattles by their handle. They're getting more into the fine motor skills at this age. 11 months old, they walk by holding on to something. And for their fine motor, they have a neat pincer grasp. They're picking up their Cheerios and putting it in their mouth. They deliberately drop objects for them to be picked up. Now, when they throw things off their tray now, it's a game for you to pick it up. When they do it at 4 months, they think it just disappears. They also like to place objects into containers. So this is like a cool thing, to get, I know these are old-fashioned, some clothespins and give the baby, a smaller necked bottle and have them using their fine motor skills and putting those clothespins into the bottle. And there's toys that they can put into, put in and take out. And 12 months. They sit down from a standing position without any assistance. They can either walk with one hand held, which is most common, or walk on their own. They tried to build a tube block tower without success. They tried to put one on top of the other, but what happens is they put so much pressure and they don't let go at the right time that it never works. But they can turn pages in a book, and it might be many pages. It might not just be one page. So age-appropriate activities. Children, infants, has the shortest attention span of all the age groups, or so they say. So they do not play with other children. You put two babies on a blanket and they're going to play by themselves. It's called solitary play. So until 12 months old, a baby does solitary play. I want you to think about what's appropriate toys and activities that would stimulate, the baby's senses and encourage their development. I'll give you some, but I want you to think of others. The solitary play, they can shake a rattle, they can look in mirrors, they can chew on teething toys, they can play patty cake, play with blocks, and they love to listen to someone read. We're going to talk about immunizations later on in the semester, but it's really kind of cool if you start memorizing them now for each age group. So in the hospital, the baby gets a hepatitis B almost always. At 2 months old, these are the shots he'll get, and it's quite a few. A DTaP, a Hib, an IPV, a PCV, a RV, I want to say the real names, and maybe the Hep B. Usually it's the Hep B, but if they didn't get it at birth, well, they'll still get it there. At 4 months old, they don't get it quite as many. And I want to tell you that some of the manufacturers make one shot with many of these in it. It won't be all of them, but it'll be many of them. They get their second DTaP, their second rotavirus, RV, their second IPV, their second Hib, and their second PVC. Oh, I wrote PVC. I think it's PCV. I'll get that corrected before you get this. At 6 months old, they can get these shots anywhere from 6 to 18 months, but generally it's given at 6 months. It's a DTaP, an IPV, a PCV, their third hepatitis B, their rota vaccine, and their Hib. And somewhere between 6 months and 12 months, they can get the flu shot. They cannot get the flu shot before 6 months. Now, you might not know what all these shots do and why we need them all. We're going to talk about it later. I just wanted you to start trying to memorize the first year shots because there's a lot of shots and it's very hard to memorize these, and you do need to know these. Some complications of infancy is a flat head. When babies are put on their backs all the time, as they are now, many times their head, because it's soft, will become flat. If you look straight onto the baby, so if the baby's lying on the table and you're at the head of the table where the baby's head is, that's the best way to check and see if it's a flat head. You sit the baby up and look at it from behind and see if one side is flattened. If so, they need a helmet, which I have some pictures of for you to correct it. Usually, if you find it at 2 months, you can teach the parents, what to do. They can, when the baby's lying on the floor, always on their tummy, not hold their back so close to their chest that the baby's putting pressure on it. The baby can, at 4 months, the baby can be put on one side sometimes and, put a little pillow behind it to keep it on that side. The baby just can't be on its back all the time or rubbing its head against something all the time. SIDS. SIDS is a horrible thing, and your book goes into detail, and I'm glad it does. They do it really well. But the contributing factors to SIDS is a male child. The baby is 2 to 3 months premature. Low birth weight. Low APGAR scores. Living in poverty. A family history of SIDS. Maternal smoking. Co-sleeping, the baby sleeping with the parent. And twins or multiple births. Those are some of the contributing factors. One thing that SIDS is really on the increase, January and February, during the coldest months of the year, pretty much everywhere. And it's in the increase, or if babies recently had an upper respiratory infection. So, and why we say poverty, for some reason, low social economical status or crowded living conditions, it's just been prevalent in SIDS, unfortunately. So the preventions is putting the baby on its back to sleep. Make sure the bumper pads, the blankets, stuffed animals, there's nothing in the crib that would, the baby could get his head under. Encourage breastfeeding. There's been less babies that have SIDS that are breastfed than formula fed. Offer a pacifier when sleeping. That's a new one. And because the baby is sucking all the time. So it won't just like drift off to sleep. You have to use a firm, tight-fitting mattress in the infant's crib. Let me see if I have anything else here. Oh, some people who are kind of nervous or it's been in their family at all, they're taught to use a home monitoring system. And one of the biggest things is not to let the baby get overheated. And then colic. Colic is the unrelentless crying of the baby. It's really most common after 2 weeks and before 3 months. The babies cry when they're awake, but they sleep good. They usually cry at the same time every day. Now, some babies, they call it the bewitching hour, cry just as the parents are sitting down to eat. And that is a little colicky period, but true colic is they cry all day long. First, the baby, and the baby cries for no apparent reason, of course. The baby needs to be examined to make sure that there's nothing physically wrong with the baby. And then there's a lot of things a parent can do for colic. They can swaddle the infant during the crying period. Sometimes that helps. Sometimes the baby wants actually to be on the floor and have the clothes off and nothing, making them feel bound up. Sometimes background noises like the washing machine or the vacuum cleaner or white noise will help the babies to relax and stop crying. A lot of times, if the baby is a bottle-fed baby, we'll switch them to a hypoallergenic formula to see if that'll help, or a formula that's like pre-digested, that's easy to digest, that's easier on their tummy. A warm bath sometimes helps. A gentle massage may also help. And then failure to thrive. Failure to thrive. There's I want to probably go to that actual chart for you. So let's go on. We'll come to 5. So here's your flathead syndromes, And there's the brachiocephaly and the phagiocephaly. The phagiocephaly really needs a helmet, and that's actually what we see the most. The brachial doesn't look so bad because it's just in the back, but a helmet would actually help that so that the baby's head grows well. This is the dock band that is used for their flat heads. I don't know if you've seen any babies in it in the store. So they fit the baby's head into it. They make it to fit the baby. They fit the baby's head into it. And then there's a little like screw or dial that they'll get directions on when they should make it a little tighter. And they make it a little tighter and a little tighter. And it's not significant. So, don't think they're like I thought, they're squeezing this kid's head. It's just to help mold that baby's head. Well, here's a baby that's a failure to thrive. There's many reasons babies are failure to thrive, but the definition is a baby that had been on the growth chart and now has slowly fallen off the growth chart. So under the 5th percentile is failure to thrive. Of course, that doesn't mean, with the little premature babies, if we put them on a full-term baby's growth chart, that we're not talking about that. We're talking about kids that probably came into this world at an average weight, and every time their weight and their height is done, they are not really losing, but not gaining. And when we measure them, they're falling off the growth chart. The bottom lines is the weight, and the top lines are the length. Failure to thrive, it's called growth failure, results from the inability to obtain or use calories required for growth. Less than 5th percentile on the growth chart for weight, or has persistent weight loss. Now, it can be a result of an organic cause or a psychosocial cause unrelated to disease. Sometimes it is idiopathic, which means we don't know what causes it. So an organic cause could be a child with cerebral palsy or chronic renal failure, congenital heart disease, or a baby with gastroesophageal reflux. Those are something we can fix, all of those. A non-organic failure to thrive can be from parental neglect, lack of parental knowledge, or disturbed maternal child attachment. It could be poverty. And I'll tell you why poverty's on here. And I've had patients do this. Formula is very expensive. And if the person isn't breastfeeding, of course, they need formula. And sometimes people that don't have any money will put more water in the powdered formula than what it's called for. So they feel they're giving their baby, a full bottle of water, a full bottle of formula, but in all reality, the baby's getting a lot of water and a little formula. So they do that in order to stretch the formula out, but in return, they're hurting their baby. Sometimes it's health or child rearing beliefs. Sometimes it's family stress, and the baby will sense family stress. Some babies are just feeding resistant, and we just don't know why. And if the parent is breastfeeding, mom is breastfeeding, some moms have insufficient breast milk. It's a sad situation, but first we have to make sure, that there's nothing physically wrong with the baby. So then, a pediatric medical home is similar to, I think, the adult medical home, and it's where the care is coordinated and it's consistent and ongoing through all types of, doctors, specialists. It's a care that's agreed upon with the parents and the child and, the pediatrician and whatever specialist the child needs from infancy all the way through adulthood. Umbilical cord banking This is a fee for service when the umbilical cord blood can be preserved and stayed, and stem cells can be used from it. It's very, very expensive, so a lot of people can't afford to do this. But many do it, and they save it in case somebody in their immediate family, suffers from a cancer or needs stem cell. I had a mom who had a child with leukemia who got pregnant on purpose, just to have this cord blood banking because nothing else was working for their child, and the child was given the stem cells from it. Taking temperatures, I don't think you very often take adult rectal temperatures, but you need to be careful with it. With children, we never use the mercury-filled thermometers, and I don't know that you use it anywhere else. A rectal temperature is sometimes, most of the time, taken for kids under 3 years old in the emergency department. If you have to take one, you're going to lubricate the end of the thermometer with a water-soluble solution and insert it no farther than half an inch into the rectum, and you're going to hold it there. You'll hold the buttocks closed because the kids will try to pop it right out on you. And we don't really teach parents how to do this at home, because if they go up too high, they could hurt the baby. So we don't teach them to do it. Things that you want to teach your patient's parents upon discharge are signs of illness, and it's in the newborn and young infant. So I think you learned how to take an axillary temperature, and generally we take axillary temperatures with little kids. Your book uses Fahrenheit, 99.3 to 100.3. We say 38 degrees Celsius. If the child is vomiting more than one time, if they really have a significant decrease in what diapers, they need to call their physician. If their fontanelle is sunken or bulging, a sunken fontanelle could mean their baby's dehydrated. A bulging fontanelle could be increased intracranial pressure. If the baby has a significant loss of appetite, not just one feeding, but a couple feedings or more. If the babies, when they come home from the hospital, if either their new circumcision or their cord has a bad smell to it. If the baby is very lethargic, a lot of times that can mean a cardiac issue that wasn't picked up right away. Increased irritability. If it's increased irritability, the baby's trying to tell you something. It could be something maybe as simple as an ear infection that can be fixed, or it could be something pretty horrible like a meningitis. If their hands and feet turn blue or are cool to the touch for a long time, we know when babies are born, their hands and feet get dusky, on and off, on and off. This is if it turns blue and stays blue. If the baby starts drooling and they're not teething, if the baby refuses to lie down, if they're 8 months old or older, and this isn't a temper tantrum kind of thing. If they go to lay down and they're screaming that, they can't say it hurts, but they're screaming like it hurts. It's very important to call the physician. Red flags that you will know that something is wrong is when the infant has no attempts to lift the head when lying face down. If there's no improvement in head control, slowly when we pull their arms up, they'd be able to bring up their head with their body. Remember, we talked about that. If they can't, or if their head's bobbling, something is wrong. If he doesn't respond to loud noises. At home, that's the best way that we can tell if the baby's, having a hearing issue. They're tested when they're born, but that's not we can't be assured that that's going to the baby isn't going to have a hearing issue. If they become extremely floppy, it kind of goes along with the lethargy. if there's a lack of response to sounds or visual cues, such as loud noises or bright lights. And that would be like a baby staring ahead, maybe having a little seizure that isn't picked up on. Inability to focus on a caregiver's eyes. They will focus on their mama's eyes. A poor weight gain. Or if they haven't started crawling by 12 months. That's delayed development, and we're in trouble if that happens to that baby. So if you come upon a child and you have to do emergency care, maybe on the side of the road, or your neighbor calls you over, and as soon as they know you're a nurse, they're going to call you over. Trust me, so don't tell anybody. You have to stay calm, and you have to do your critical thinking. You have to, if the baby's not breathing, you're going to begin rescue breathing. You're going to have someone call 911. If they're bleeding, you're going to apply pressure with a clean cloth. If they're having a seizure, you're going to make sure that they're lowered to the ground, that there's nothing in their mouth, that you turn the head to the side, and that if they have any restrictive clothing on, that you loosen it. If a baby is seriously injured, don't move them unless you have to, like it's unsafe. Burning house, burning car, they've been underwater, or we worry about their neck, so don't move that child. Always stay with the infant until the help arrives. If you've been told that the baby has maybe taken medication or something that's poisonous, bring it with the child to the hospital. Because being the next door neighbor, you're probably going to be the one driving. And be sure that you or the parent can provide an accurate history of the events as they occurred. And the hospital is going to want to know, the nurse at the hospital that you see is going to want to know, when was the last time the child ate and what did they eat? I put shaken baby syndrome here. Shaken baby syndrome is a form of child abuse. And when children get maybe irritable and people can't tolerate children, they're maybe too immature, they're not ready for it, they end up shaking the baby. Most of the kids that have shaken baby syndrome are under 1 year old, and it's usually between 3 and 8 months. Although toddlers between 1 and 2, I've seen several, but keep that in mind. But it's most dangerous under 1, most common between 3 and 8 months. The baby, how you're going to tell is that the baby will have hemorrhaging in their sclera, corneal hemorrhaging. And the only thing that can cause that is shaken baby syndrome. They may have a detached retina. Actually, they call it retina hemorrhaging. And they may have a detached retina from it. That's the first thing that happens. Unfortunately, many times brain damage occurs, and many times the child dies from shaken baby syndrome. If you're the nurse in the ER taking the baby in, you'll want to know who the baby was with, and was it a babysitter? Is it a caregiver that always takes care of the baby? Are the parents like teenagers or young? And for some reason, it says the research suggests that teenage fathers are more likely to cause shaken baby syndrome. And we do see it more likely with fathers. They just can't, tolerate it. Generally, they'll be immature and not be able to handle the baby's crying. So hospitalization can wreak havoc on this child and his parents. First of all, the child can't explain, what hurts or what's wrong. And then the child can understand why things are being done and why he's in a weird environment. In fact, some of the studies show that babies have anxiety from the strange environment. They don't sleep well. They actually wake up for little tiny sounds. And imagine if they're on a monitor and that thing's going off at night. They sense their parents' anxiety at the same time. And remember, if their parents cannot stay, they're going to suffer from separation anxiety as well. So, as nurses, we try really, really hard to encourage the parents to come and stay and be comfortable. Now, we can't put any guilt on them if they can't stay. Sometimes they have other children or they have to work. And in that case, we can move the baby to a room that's close to where the nurses are. So when that baby cries, the nurses can go in there and meet the baby's needs right away. Another important thing is that we have consistent nurses, the same nurse taking care of the baby. So not every time the baby turns around, he's unfamiliar with, the person taking care of him. In the hospitals, they have a child life specialist. And this is actually a person with a bachelor's degree that goes to school for this. And for older children, it's a godsend. For babies, they can bring colorful mobiles and music boxes to babies under 3 months. At 3 to 6 months, they can bring noise-making objects that the baby will like. For 6 to 9 months, teething toys and even just socially interacting with the baby. And then 9 to 12 months, they can bring large blocks to the baby. If the baby's walking, pull and push toys. Really, the child life specialist in this situation will actually be more comforting to the parents because, she can't play games with the baby. She can play with him if no one's around. But she'll be the most comforting to the parents. And actually, a lot of times she can explain the procedures to the parents and they'll listen to her because they're not threatened by her like they might be a medical person. Okay, so infant's response to pain is going to be a little different than, the older child's response to pain. We'll see an increase in the blood pressure, respirations, and heart rate. And the increase actually is kind of right away, and then things will slow down. There's a decrease in oxygen saturation. The baby's cry changes. It's harsh, it's tense, and it's really loud. If you look at the baby, they'll grimace, they'll have a facial grimace, they'll flinch every time you touch them. Their eyebrows will furrow, or your book calls it bulged eyebrow. When they cry, their chin will quiver, and they'll thrash all their extremities. If you look in their eyes will dilate, and they'll be sweaty. So infants' response to pain is a little different because they can't use it. But there are pain scales that the mother and the nurse can use. The NIPS pain scale is actually used for infants. It was originally used for the premature infants. So some of you that go to the NICU, ask what pain scale they use. Now there's several pain scales, but this was the one that was initially for the premature, but now we use it for infants. And you can you go down the list and you score it. If, it's a yes, it's a 1. If the baby has more than 3, the baby's probably in pain. The one that's most common for infants is the FLAC scale. That's from 2 months to 7 years. It's quick and it's easy, and it's real similar. And the FLAC, it stands for face, legs, activity, crying, and consolability. So again, you're going to look and see if there's no expression, give them a 0. If there's a frequent quivering chin or their jaws are clenched, it's a 2. The higher the number, again, over 3, the more problems the child is having, or the more pain the child is having. Nursing interventions for the child, for the infant, might be right away, if it's a severe pain, post-op or something, IM or IV injections. I put the IM shots sites here for you. For a baby, we generally use the lateral aspect of their thighs. That's used, until they're walking most of the time. We also can use the lateral gluteal, but it's very rarely. We're so afraid we'll hit that sciatic nerve. So generally, an infant, you're going to use the lateral thigh. Kids that can walk will use the deltoid. Oral medication can be given to kids. And what we usually do is put the baby in a nursing position or a semi-Fowler's position. We get a syringe and pull the liquid medicine up into it, put a plain nipple in their mouth, and shoot the medicine in slowly as they suck the nipple. That's the best way and the easiest way. If you don't have a nipple, you just put just a touch, and I can't even tell you how much, like, 0.1 of a mil inside the sides of their mouth. You go side and a little bit back, and you wait till you see them swallow before you put any more in their mouth. There's also non-pharmacological pain reliefs. So there's music therapy. There's actually animal therapy works. There's massages. There's what do they call it? Smell olfactory therapies. So a lot of times these will help the baby if they don't have, let's say you think they're in pain, but they're not more than a 3. Let's say they're a 2. They probably don't need morphine, but maybe some of these non-pharmacy therapeutic measures would help the child. So back in a couple chapters earlier, I did tell you, I think, that we're going to kind of pull those into each age group. Infants' reaction to death, they don't understand death. All they understand is if their caregiver is unhappy, if their parents are stressed and crying. So what they might do is they might cry more. They might sleep more. They might eat less because now they're stressed because the people they love is stressed. If it's like they're 9 or 10 months old and it's one of their parents that has gone, we can see that they have an increase in separation anxiety from the parent that's still with them. And safety and injury. This is so, so, so important. Let me get my little list for you. I know I have it here as well. So the first thing on the list is aspiration. Babies need to be given age-appropriate toys. That's one of the reasons we have a lot of aspirations in babies. Small objects such as grapes, coins, and candy should not be given. Okay, check clothing and household objects for safety hazards, such as loose buttons or drawstrings. Loose buttons is a big problem. So, babies don't wear a lot of shirts and stuff with buttons anymore. But they might have a little rag doll that has a loose button. It could be your loose button, or if the baby has something with a loose button on, that is really a huge aspiration issue. Suffocation, we keep all plastic bags and balloons out of reach. There's no pillows or heavy blankets in the crib. We make sure that the crib rails don't go down anymore and that the slats are no farther than 6 centimeters apart. We also make sure that the crib mattress fits snugly, and we discourage co-sleeping with the parent. Bodily harm. Keep all sharp objects out of reach. Make sure the furniture is anchored down. Do not leave child unattended with animals. And monitor infants for shaken baby syndrome if you have to leave them with someone. Burns. Check the temperature of the bathwater before you put the baby in. And the best thing to do is set the hot water thermostat below 49 degrees Celsius. Keep working smoke detectors in the house. As they get, 9, 10 months when they're pulling up, turn the handles of the pots and pans to the back of the stove so they don't pull up and reach up for one of those. Apply sunscreen if infants will be exposed to the sun. Cover the outlets. And one thing you don't do is you never heat, well, you're not supposed to heat their formula or breast milk in the microwave. The breast milk, it'll break down the proteins and they won't get the right nourishment. But both of them, you know that microwaves heat from the inside out unevenly, and it could burn the baby. Drowning, do not leave babies unattended around water sources. Cleaning buckets, they may pull in and fall into it. Toilets, tubs. Secure fencing around any swimming pools and close the bathroom doors. Falls. Keep infant seats on the ground or floor if used outside of the car. Sometimes people use it as a little chair for the baby, but it needs to be on the floor. Multiple times when I was in PDR, people would come in because they put the little car seat or the baby seat up on the island or counter, and the baby fell out of it, or the whole thing fell. Place safety gates at the top and bottom of stairways, and make sure that the baby has the crib mattress in the lowest position with all the railings always up. And well, now we don't use rails, that'll go down. Poison, keep poison control number available. Avoid exposure to lead paint. You know, the older homes, if the people are renovating the house and scraping the paint off, make sure this baby isn't exposed to lead paint. Keep toxins and plants out of reach. Use safety locks on cabinets. Store medicine in childproof containers and place high out of reach. And maintain a working carbon monoxide detector in the home. And I'm going to tell you, this is the only age group that motor vehicles isn't number one injury. All the others it is, but it's a huge problem. Newborn infant seats should be placed in federally approved car seats at a 45-degree angle secure with safety belts. They should be facing the rear of the car. Place the shoulder harness in slots at or below level of infant shoulders. Place retainer clip at axillary level of infant. Rear facing, now I think it's until, I'm gonna double check this for you, but your book says 2 years of age. But I think it's actually has gone up to 3 or 4. I'll check that out for you. And if for some reason an airbag is near the infant, the passenger seat airbag should be inactivated. Wow, that's a lot. So read your book now that you have what I think is important from that chapter. And I pulled in other sources that you need to know. You know, NCLEX and ATI, you know, they don't always just say exactly what your book says. One thing is, you know, I gave you heights and weights, and I gave you vital signs, and those are the ones that you need to know. You know, your book might be slightly different. Your book is a wonderful book, but is a lot of information. But now that you have the basis, go back and read your book. You'll find it interesting. And I'll see you at class.